Okay, let's talk about the cervical spine. So in the cervical spine, we have more mobility compared to the thoracic spine. We say that stability is sacrificed for mobility. So remember when we were trying to isolate the different parts of our spine and we had lots of rotation and lateral flexion in our C spine compared to our thoracic spine, our T spine. Because it's more mobile than stable here, it's more vulnerable to injury. We know that the cervical curve is lordotic, and then we have our kyphotic thoracic spine, our lordotic lumbar curve, and our kyphotic sacral curve. And we know that there are 7 cervical vertebrae, C1 to 7. So in our cervical spine, just like the thoracic and lumbar, we have our intervertebral joints. Intervertebral, these are classified the same. They're cartilaginous, symphysis, and they're amphiarthrotic. So these joints exist throughout the spine, except between C1 and C2 and the occiput in C1. So no cervical disc here, intervertebral disc, excuse me, and none here. This is the first intervertebral disc we see between C2 and C3. And then we also have, just like the rest of our spine, our zygapophyseal or facet joints. And just like the rest of the spine, these are synovial planar joints, diarthrotic. So this is an anterior view. These are both anterior views of the cervical spine, and we've just shaved away some of the bone here. So here are those facet joints or zygapophyseal joints in the cervical spine. And then our typical cervical vertebrae, so C3 to C6, have those uncinate processes. So it's kind of just a lip that extends and creates some interlocking. So we don't talk much more about these joints. They're called the joints of Luschka or the oncovertebral joints, oncovertebral. And we just need to know that they exist in the typical cervical vertebrae, but we don't need to classify them. Okay, so here's our facet joint in its little capsule. Here's our typical intervertebral joint in the cervical spine. And we talked about there being no disc between the occiput and C1 or C1 and C2. There are those oncovertebral joints or joints of Luschka. So we just know that they're interlocking, they provide stability, and they're from C3 to C6. So atlantoaxial joints we'll talk about next. We have our median atlantoaxial joint, and we have our lateral atlantoaxial joints. So the median one is a pivot. Okay, so here's C1, a superior view, so looking down, and an inferior view looking up from under it. And here is C2, an anterior view and a posterior view. And the big deal with C2 is this dens or odontoid process, same thing. So the median atlantoaxial joint is the articulation of the dens with the tubercle of C1. So here is that articulation. The dens meeting C1. And this just, these slide around and it's just a pivot joint here. So shaking your head no, answering no, is pivoting or cervical rotation. And that's the movement that occurs at this median atlantoaxial joint. So this little area posteriorly, that's where the transverse ligament will secure it into place, this joint. So this posterior little facet articulates with the transverse ligament, and then this is it anteriorly, and that's where it will articulate here with C1. Here's a superior view of that same joint. So we can see now that transverse ligament holding it into place. And this is the dens from above. The lateral atlantoaxial joint is the facet joint here at C1, C2. So it's a planar joint, just like all the others. So that joint will be this facet on each side articulating with this. Remember, this is an inferior view. So it's just these little facets articulating together. So this joint here. So we saw, this is that posterior view of both of those joints. And then we saw this superior view of the median atlantoaxial joint. And then here's an anterior view of those joints. So there is that median atlantoaxial joint, and here is the lateral atlantoaxial joints. So a few different views of those. There's that lateral atlantoaxial joint again, so a synovial planar or gliding joint. We did the palpation in those separate videos. I will upload another video of finding the TVPs of C1 from the supine position, and let me know if you want to see anything else again or from a different angle. So a few ligaments here. Let me show you this picture. So here's that cruciate ligament. So there are several parts. There's the superior longitudinal band, the inferior longitudinal band, and then the transverse ligament. So that one is important because it holds the dens in place, that transverse ligament. So what makes up the cruciate ligament? The transverse ligament, most importantly, I would say, and then the superior band, the inferior band. This picture down here, we've taken away the cruciate ligament and some bone too. So we're looking deeper. And those two ligaments are the alar ligament. So it goes from kind of either side of the dens, holding it into place. And then the apical ligament, this little guy here. So we also have the tectorial membrane. And remember, that's just a continuation of the posterior longitudinal ligament. So the PLL goes from the sacrum all the way up to C2, and above C2, now it's called the tectorial membrane. So they're the same continuous band. The supraspinous ligament, here it is. So here's C7, here's C7, here's T1. So down here it's called the supraspinous ligament. And then superiorly, all of this is the ligamentum nuchae. So we're not just looking at this little band anymore. We're looking at this whole really broad thing. And if you haven't already, you'll see that the ligamentum nuchae is an attachment point for some muscles like the upper trapezius. And it's just this big broad band of fibers here. All the other ligaments like interspinous, intertransverse still exist throughout the whole spine. So they still exist in the cervical spine. So there's that picture of the supraspinous ligament becoming the ligamentum nuchae. So a big kind of broad band. And then we have our atlanto-occipital joint between the occiput and C1. So this is a posterior view of that joint, and it's covered by this membrane. Here is an anterior view, and we're seeing ligaments still intact. But here's the joint. So here's the occiput, and there's C1. Okay, so here is an inferior view of the skull. And here's that superior nuchal line I was talking about. And in the middle of it is the external occipital protuberance, the EOP. And then we came down a little bit until there was another ridge, and that's the inferior nuchal line. So the occiput, here's the occipital condyle on each side with the little blue cartilage. That is what is articulating with C1 here. And that makes up the atlanto-occipital joint. So that's our last joint here. The atlanto-occipital joint. And this one is a condyloid, a synoviocondyloid or ellipsoid joint. So this is where those bobblehead movements occur. So a little bit of like yes motion with your head, a little bit of a bobblehead on your dashboard, picture that. So nodding the head just slightly up and down, and a little bit of lateral flexion. And then a bit of circumduction occurs here. So that makes it triaxial. So here's just a more simple kind of drawing of those occipital condyles on C1 meeting with the occiput. And this is just showing how it's a condyloid joint. So for these ligaments, we have the posterior atlanto-occipital membrane. And then the capsule of the atlanto-occipital joint, just these lateral kind of thickenings of the joint capsule, are the lateral atlanto-occipital ligaments. So same thing. And then anteriorly, we have the anterior atlanto-occipital membrane. And then these would be those lateral thickenings of the joint. So cervical spine, I mean, you could say upper traps, sternocleidomastoid are probably some of the more important ones here. If you guys haven't done the C-spine yet, but you'll learn lots of applicable muscles. I feel like these two are easiest to remember. They're big. And then cervical arteries, this is just a visual for you. Same with nerves. And then pathologies, I'm sure everyone's heard of whiplash. So an impact from behind, posterior impact. There'll be hyperextension and hyperflexion. This can be any like acceleration, deceleration injury. So it doesn't necessarily have to be a car accident or from behind. Whiplash is referring to kind of acceleration and then deceleration of the spine. Cervical rib, this will only occur at C7, so not up here. So just C7 having kind of extra bone growth on it. And then it leads to, because we have the cervical plexus here, just compression. Thoracic outlet syndrome, another kind of compression thing. So this can actually be compressed at a few different places, but basically it's going to be compression of that brachial plexus that comes out. And then depending on where it's compressed, we could have artery effects or vein effects. So circulation stuff might be going on, tingling, numbness, that kind of thing. So we're just looking at a hypolordotic cervical spine here. Some disc thinning in this picture. And here's that vertebral artery running through the transverse foramina of the cervical spine. So there are those transverse foramina. There's the vertebral artery. And then in your notes we discussed kind of being too far kinked to one side. So for a sustained amount of time, in theory, this could implicate the contralateral, so the vertebral artery on the other side, the side opposite the bending, opposite the lateral flexion. So one more shot of the median atlantoaxial joint and the lateral atlantoaxial joint, or the facet joint here between C1 and C2. Here are the articular facets for the atlanto-occipital joint, so the occipital condyles. There's that cruciform ligament, so alar. Apical will be underneath that, deep to that. There's that important transverse ligament. There's that EOP, so superior nuchal line, inferior nuchal line. So when we have the head, when we're palpating it prone, we kind of find that big bump first, and then to make sure you're in the correct spot, or just to feel it, you can palpate on either side to find that superior nuchal line. Dip down into that kind of flatter, smoother spot, and then keep going, and you end up on this ridge, the inferior nuchal line. And we're basically, when we're palpating the atlanto-occipital joint, we're getting as close as we can to these articulating surfaces, but of course it's deep, so we're using these as our little landmarks to get there. Here's the mastoid process. So this is your external acoustic meatus, or your ear, so your ear hole, and we're coming right behind your ear to feel the mastoid process, and it's big. And when we go to the transverse process of C1, we're coming to the inferior, more anterior portion of the mastoid process. So it's pretty big, and you're not just coming off anywhere. I recommend coming off closer to here. And then there's the angle of the mandible that you'll find on your body, and you're meeting your fingers kind of in between here to get to the transverse process of C1, which, look how wide it is. So there's the TVP of C1, and now it should probably make sense why we're coming so kind of far, almost anteriorly or laterally, it might feel like, because it's just so wide. Those TVPs stick right out for C1. And there's that angle of the mandible again. And that is the cervical spine. So me and my TA Skeeter will sign off. Okay.